A good day to everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome you to today's Research in Progress webinar on improving the efficiency of newborn screening from collection to test results. Before we get started, we would like to acknowledge the funding and support of the Robert Wood Johnson Foundation. I'd also like to bring your attention to the chat box in the lower left-hand corner of your screen where you can type in questions at any time during the webinar. So without any further ado, it is my pleasure to present to you, introduce to you our speaker for today, Dr. Beth Tarini, who is the Fred G. Smith Chair of Academic Pediatrics and a Division Director of General Pediatrics at the University of Iowa. Her research focuses on optimizing the use of genetic testing technology in pediatrics. Dr. Tarini is particularly interested in the organization and delivery of healthcare services through population-based screening programs such as newborn screening. Beth received her medical degree from the Albert Einstein College of Medicine and completed her pediatric residency training at the University of Washington. She is a graduate also of the Robert Wood Johnson Clinical Scholars Program at the University of Washington, where she also received a Master of Science in Health Services. So with that, I'd like to turn it over to you, Beth.
Thank you, CB. Thank you, everyone, for coming. And, of course, thank you to the Robert Wood Johnson Foundation, as well as Systems for Action, for funding this, what I believe, the important work. So I'm going to talk to you today about the project background and objectives, talk about the results, and also where we go from here in our next steps with this project. So brief orientation about newborn screening. What I want you to be aware of is that it's a complex process, and it requires coordinated and timely collaboration between multiple stakeholders, both within and between clinical medicine and public health. Often people, when they think of newborn screening, which is the testing blood, hearing, and oxygen testing done in the first 24 hours, after 24 hours of life, they think of the testing only, and they don't think of everything else in the system that has to go with that testing to actually figure out whether or not that child is at risk for an inherited disorder that we can actually impact in a meaningful way. And so I came here to study the system and how to make that system work more efficiently. So you should also be aware there's different ways to organize and deliver newborn screening because each state designs its own process. Each state governs its own newborn screening program. And at the same time, I recognize that there's more than one way to skin a cat, that different designs can be equally effective. But a saying we have in the field, in the community, is if you've seen one newborn screening program, you've seen one newborn screening program. So this pictorial is from the Minnesota Department of Health. My colleague Amy Gaviglio there in charge of follow-up created this to get people a sense of the baby's born, what's going on. We then get the tests done, blood, as I mentioned, heart, hearing. Some are done at the bedside, like hearing and heart. Others the blood needs to go to the Department of Health. At that point, the testing occurs. I say the Department of Health, it could go to another outside lab technically, but it goes to a laboratory to conduct the testing, and from there the results are generated and they are then called out, and then the further evaluation takes place. In this project, we were focusing on the piece of the system that occurs between birth and getting the blood spot to the lab for a number of reasons, many of which had to do with feasibility and current data availability. But I do recognize that that process doesn't end with the blood getting to the laboratory. So let's go deeper into that box that I just pointed out. We have in the first, we've separated this, and we've gone into this project into basically three sorts of phases. First, there's a collection and all the issues that go into the collection, and that takes place in the hospital, as you'll see here. There are issues of timing, who's the agent of the collection, what's the staffing and the availability to get that specimen collected. Then the specimens are picked up and transported from the hospitals to the facilities where they will be tested. And to give you a sense of scope, in Michigan, where much of this work was done, there are 83 birthing hospitals. So you have to get the specimens from those 83 birthing hospitals and birthing facilities, I should say, throughout the state, the Upper Peninsula and the Lower Peninsula, to Lansing. And so that is no small feat. And then at that point in time, the processing begins. And that, of course, some major factors in that would be staffing and timing. And the goal is that all of this happens within 5 to 7 days. And these are based. This goal has been solidified by the Federal Oversight Committee, that is the Advisory Committee for Heritable Disorders in Newborns and Children. And so this is the goal now that all are operating under. And so people have said, this slide is, people have said, let me back up, well, we can get to 7 days, I'll give you the example, if we just open the lab on the weekends, because not all the labs are open Saturdays and Sundays. And this is where my project was born, no pun intended. That if the specimen arrived on a Saturday, on a Sunday, and the lab wasn't open, and we couldn't get it done until Monday, or arrived on a Saturday and the lab's not open, it has to wait till Monday. Now we've lost 2 days, and we can gain those 2 days back by just opening up the lab. But in fact, what that misses, I believe, is the inefficiencies that are in the system. We might have been able to get the specimen there on Friday, at which point this is a moot issue. And so that's why we were looking deeper into what's the actual processes. And in some ways, it's this slide, the goal is to say it's like waiting for a bus. If you get on the right bus and the courier picks you up at the right time when that specimen is ready, or in this case, this is the subway, the DC subway, I believe, then you have made it. You haven't waited. You're not waiting for the next courier, the next subway, the next bus, the next courier. So there's that process of efficiency. There's that process in how efficiently it happens until that courier picks you up, and how that courier delivers you. That also needs to be examined. And so in this process, our goal was to take a broad perspective of the process, to perform a systematic analysis and identify those leverage points in this process where we can potentially intervene and improve process efficiency. So our aims were to identify those strategies that will decrease time from specimen collection to return of results, and then determine incremental trade-offs between time, costs, lives saved for decreasing time from specimen collection to the availability, and then, of course, rapidly disseminate those findings, because we don't want them to live in an ivory tower or in an echo chamber where no one hears them. And so, and aim two, we recognize that there are a lot of things we could do to change and optimize a system. The question is, what is the bang for the buck, and where are our resources best spent? So what we undertook for methods was a simulation modeling to identify these leverage points, if you will. And so what is simulation modeling? It's basically a statistical method used to identify steps in a newborn screening process that can be modified to improve timeliness. So we just basically run the computer will run simulation after simulation, as if running real-world tests numerous times, to figure out where statistically the leverage points are. And so what are the implications? So as I mentioned, the computer's running these simulations time and time again. It's a systematic and efficient method for assessing the timeliness of a process, of a newborn screening process, but in any process really. And it can help us identify these steps in the process, and we can tailor it to state-specific processes, and that will come up later in terms of next steps. So some early challenges, you always start out thinking all these great things you're going to accomplish, and then reality hits, even when you've written a grant and involved all the stakeholders. Then when you get really into the nitty-gritty of the real world on the front lines, you realize that not everything is as rosy as it looked from 5,000 feet. So we recognize that there's process complexity, even more than we who had been working in this field for decades recognized. That there's variability in the organization and implementation at all levels, including both the hospital levels and the program, and that matters, as I said, given the scope of hospitals, 83 hospitals, for instance, in the state of Michigan. One can only imagine the number in California, for instance. And the availability of the necessary data to do the simulation. So people may have data. First, do you have the data in the program and or the hospital? Second, if you have the data or you collect data, is that data even valid? And that we wanted to make sure when we were using data that it was valid, and we believed that what we were collecting was truly the truth. And then trying to get a handle on what are the health outcomes of a gain of less than 5 days. And it might surprise you to know that we don't have systematic, not of course not on the national level, but even at the state level, a few states have sort of systematic data on that they can pull out and say, okay, for X disorder X, the average day of presentation without screening is X or Y, or these children presented clinically at day 4, but their screening came back at day 5. And so that made it very challenging for us to understand what would be the gain of hours to a health outcome if we were to make that improvement of a few hours. So, this slide. Back to model development. So we created this model, and we did it with a combination first of using information from Michigan birthing hospitals, which was given to us by the, which we used in partnership rather with the Michigan Department of Health. And so we had data on 94,770 specimens from 83 birthing hospitals or facilities over this year period. And we did not include newborns from the NICU or special care unit because their process of collection is much different. And so we included only the sort of well baby nursery, if you will. And we had the following variables that you see here: time, date of birth, collection, and receipt of lab arrival, mileage from hospital. Much of these are time stamps that we were fortunate enough that the state of Michigan had started collecting. And so here you see the first pass, which is what we found in just sort of looking at patterns of these specimens. So some of these are not unfamiliar or surprising to you who work in the health system or in a nursery setting, is that most births are not random. And they are more likely from Monday through Friday, less likely Saturday and Sunday. As you might imagine, that is the result of scheduled inductions, scheduled deliveries, essentially C-sections, vaginal deliveries that are scheduled. So the reason this is important is because, and this was a great learning experience for me, the healthcare engineer on my team, when we were presenting, or we were working through this project, said to me a very elemental question, which was, Beth, are births random? And I was like, I don't know. I don't know. So the reason we had to know that is because if the system is random, then we'll know what design interventions we might have to do. If it's not random, then we know that there's a pattern essentially, and that we can then create countermeasures that are reactive, if you will, or tailored to that pattern. The same thing you see to the right with hours of birth. It's not random when a baby's born. Again, you see a spike at 8 a.m. Many who work in the newborn nursery or the labor and delivery floor laugh because they say that is when the first time of the OR occurs. Everyone goes into the OR in the morning for their scheduled C-sections, or people laboring overnight who have failed to deliver vaginally will move into the C-section suite. So you'll see that that the system itself is intervening with nature, if you will, to create these patterns, which are important to know. The other is in the blue, you have the day of collection. So collection cannot or should not occur until at least 24 hours after the birth for specimen quality issues. And so you see here basically a shift of a pattern you see in the day of birth. That 24 hours after Saturday is Sunday, 24 hours after Sunday is Monday. Those are the 2 days of the lowest collection. And because in Michigan everyone seems to be collecting very consistently 24 hours or 24 to 30 hours, you see the shift in that pattern. And then hours of collection is a bit more varied, and that's likely due to the way the hospitals organize how they collect those specimens. So again, this slide is to show you that knowing these patterns and looking at the patterns is one of the first steps to designing an effective and efficient system to meet your needs. So when we did additional patterns, we saw that the birth, as I mentioned, to collection hours was very narrow. Michigan was very good, Michigan hospitals, at having a very narrow window of collection, that they weren't spreading out to 36, 48 hours, which to some degree created, when we did the simulation, took that variable sort of out of play, if you will, because there wasn't much improvement or much sort of juice to squeeze, basically. And then if you look below that at the collection to lab hours, that's the time it took to get from collection to lab. You can see a bigger sort of spread, and that, of course, is due to courier type, location, pickup, how hospitals are scheduling the pickup, and if the lab is open to stamp them, because again, the lab was open on Saturday morning in Michigan, and so if the lab's not open, it didn't technically arrive yet because it hadn't been stamped in, if you will. And then you can see in the green the different hours of the weekend pickup and the weekday pickup that we have, and this shows you how the different hospitals schedule their pickup base and the spread of that based on during the week and how it varies based on the weekend, Saturday and Sunday. So when we put all of this into first the regression model to see what was significant in terms of improving the time or related to the time, we saw a number of things come up, as you see here with this, the statistics, that for instance, being collected on a Friday was increasing your time, which is not necessarily surprising, because if the labs aren't open and you're collected on a Friday, you're going to sit over the weekend for some period of time. You'll also see that, not surprisingly, mileage was related to the time it took, and as well as there was a between hospital variance. So interestingly enough, volume did not play a role, as you see here. And then we asked ourselves, okay, knowing all of these regression pieces, in this regression, and what was and was not significant, what about these timing? What about the timing that could be, collection timing could be important to the timeliness through relation to the lab hours and courier schedules? And so we basically started to focus on the collection time. Again, as I said, we know that from that collection timing, we have a bigger spread in collection to lab. We don't have a big spread here. So what we did was then started to run the simulations using the patterns of birth we had seen, including uncertainty, the birth to collection with tests ordered after 24 hours of birth, the simulation of different collection to pickup time, and assuming a fixed transit time of 10 hours, and also assuming processing starts immediately during lab hours, meaning when you get the specimen, the processing would start, which reflects reality, as well as the varied laboratory hours and varied pickup schedules. So you see at the bottom here, in Michigan, a typical pickup time was 6 p.m. and specimens arrived 3 to 4 a.m. Hospitals with their own courier systems have tended to have shorter transit times. And a courier can be defined, doesn't mean a private courier, it could be FedEx, UPS, or a private courier. In Michigan, there is one courier Quest that is used for most of the state. And then these are the Michigan lab hours you see here, 7 a.m. to 5 p.m. and Saturday 6:30 to 4 p.m. So what you see here is the birth to arrival times, specimen arrival times at the laboratory for different different pickup simulations. And what you see is when you start to change both the timing of the day, we did multiple of these, but these are ones I'm just showing you, as well as the days of the week you're open, you can see the spread occur in the simulation as to how fast those specimens get from birth to the laboratory. And that's what this simulation was meant to say. Rather than tweaking the system one by one, let's do it in a simulation model and see what we can pull out ahead of time. So we ran 35 pickup schedules, 6 days a week, doing 12 a.m., 6 a.m., 12 p.m., 6 p.m., or 9 p.m., and then ranked the schedules on metrics, and then again fixed the laboratory hours Monday through Friday, and as you see there here below, as well as Saturday. And what you can see here is they are here ranked on the mean time. Now you could rank this a number of ways, obviously. You could say I want most, how many can I get there? How many are there greater than 48 hours? How many are there greater than 60? Am I sacrificing some outliers there essentially for the average? But what we found was in the rank, the quickest mean time was a pickup of 12 a.m. Monday through Saturday. And then the other thing I should mention is that for each laboratory schedule, we assumed that, as I mentioned before, we assumed the courier picked up 10 hours prior to when the lab opened each day. And then this is the variation here you see is what if we say the lab hours were to change and we were to shift them. We would have said this is the normal lab operating period. Here you see in second we've opened it on Saturday and Sunday, and you see a drop here, for instance, in the mean hours. And so from these findings, what we concluded was that we could potentially intervene to reduce gaps between specimen pickups. And we could do this by a few ways, potentially. There were considerations that shifting the typical Sunday 6 p.m. pickup to a Saturday 6 a.m. would greatly reduce the number of samples with long birth to pickup times. That's understandable because obviously if you're not open on Sunday, you're waiting. Those specimens are just waiting for the lab to open. Now, there's a important caveat here because again, it goes back to aim 2. We don't necessarily have the courier's availability in certain rural areas, and this would require the Upper Peninsula versus Lower Peninsula for the state to look into other ways to reach those hospitals. So it's not to be assumed that we have in every case an a la carte menu to say, okay, let's just call up FedEx or whoever it would be and have them pick up on this day. These results need to be interpreted within the context of the state and the availability of not only resources but the availability of the service itself. And then also we noticed that a 6 a.m. Saturday pickup reduces the largest gap between consecutive pickup times. So for instance, a 6 a.m. Saturday pickup occurs exactly 36 hours after the latest pickup and 36 hours before the next pickup. So you've sat it right there in the middle to sort of hedge your bets and make everyone sort of even. But if you have shifted to a 6 p.m., you're now giving up 48 hours after the latest pickup and 24 hours before the next pickup. So these details are just to show you that the state then would be left with what do we want to do and what's important for us and what are we trying to achieve. But the goal of this simulation was not to sort of present to the states, oh, here's what you have to do. The goal of this simulation was to show the state programs that there is a way for them to think systematically about how they've designed a program or process that's been largely iterative and or step back at the very least and assess what they've designed and say, is it working for me? And before I even begin to change something, what would be the effect of my changes? And then finally, the potential intervention, we could also have more frequent specimen pickup, right? We could adjust the specimen pickup to account for the specific patterns of birth. And so we could have a 7-day schedule as opposed to a 6-day schedule to reduce those wait times between pickup and the lab not open. You could also increase to a twice daily 7-day schedule to reduce the samples birth to pickup of 48 hours. Again, to reiterate, I know I sound like a broken record, but this has a cost to it. And the question at the end of the day is that cost of resources, what is it going to give you in terms of impact? And so in conclusion, we in the simulation found that the time from the collection to receipt of the specimen at the lab is an important bottleneck in this process. And that pickup schedules and lab hours can be adjusted to improve these patterns if we account for the patterns of birth as well as when the laboratory is open. And that we can a priori, as I just mentioned, using simulation, estimate what the impact will be on our timeliness outcome. But again, we must consider the cost of changing the courier, the lab schedules, contacting the primary care provider, lab processing, et cetera. And so limits, of course, this was a model output focused solely on Michigan, and the pickup times may be limited, as I mentioned, by the availability of transport and did not consider the cost of process change. And so this project is revised and resubmitted to Maternal and Child Health Journal right now. Dr. Cochran, who was our simulation expert, and Dr. Zayas-Kavan, our healthcare engineer, Dr. Mary Klein, who is the program director at Newborn Screening in Michigan, and myself are all the authors. And we have presented this work widely, I believe. We've presented to many key stakeholders. We presented at the Newborn Screening National Meeting, where you have very large attendance of all of the programs. I presented at the University of Iowa. I presented at the federal level to the Secretary of HHS Advisory Committee on Heritable Disorders, to the Genetics Collaborative in the Heartland, where they have the confluence of multiple programs there and multiple stakeholders at all levels in those programs, and as well as presenting here to the PHSSR. And I can tell you that which is interesting and a learning point for me, is what in the world of health services is a very common approach, I would say, to solving a problem like this, was perceived as a very novel approach to the community of newborn screening, and was very well received, very widely received, and multiple people have come up to me and asking me, how can I use this, after many of these presentations, how can I use this in my program? And so that was very illuminating to me as sort of a bridge scientist, if you will, of taking something from one domain, applying it to solve or address a problem in another, and the impact that can have to improve systems. And so we have other parts to this project as well, which we're wrapping up now. We had attempted to get some additional granularity on the details about how the newborn screening laboratories and programs ran, so we can have a better understanding of the costs and constraints and and their specific processes, and also identify potential strategies for decreasing the time from collection outside of the simulation model. And ironically enough, we, to some degree, this work had not been done before, because people were operating in silos, but they would still speak with each other and problem solve by cross-pollinating. But there wasn't this larger 30,000-foot, if you will, view of what's going on in laboratories across the country and what are the different strategies being used for those processes. So what we did was, with the help of the Association of Public Health Laboratories, who is the professional organization for these laboratories, we did semi-structured phone interviews with state laboratory personnel, state newborn screening personnel, in November and December. And we did a targeted sample of 16 state programs, selected based on geographic location, testing volume, laboratory organization, and conducted these phone interviews 45 to 60 minutes, asking specifically about how the mode of delivery, timing, and specimen prep, the laboratory testing processing procedures, notification procedures, laboratory staffing issues, and quality measures and data sharing. And we had 13 consented to interview. We did a qualitative content analysis, and with a coding schema created a priori, but a final coding schema including 22 codes among 6 topic areas, describing the processes and procedures that are both similar and different across lab sites. The goal being to identify patterns, potential gaps, and as well as best practices that could be targeted in the future for additional impact on timeliness. And they're, of course, within the sphere of influence for the state labs. And so we found some interesting points, processes that were similar across labs, sample preparation, the way they actually go through and prep the specimens as they go through the sample, which is not surprising because these tests are fairly highly specific, the daily cutoffs for sample receipt, and the reporting procedures, and their interest in identifying and informing stakeholders about these timeliness issues. Things that differed: transportation and tracking procedures, timing of the delivery of the specimens, the prioritization of the processing, lab hours and staffing, as well as certain technology that was used within the laboratory. And then potential gaps that may have a significant impact on timeliness: lab responsibility, which parts of the process does the lab have control over, which parts of the process should the labs track, as well as common definitions which would enable which quality metrics would need to be defined consistently and need to be meaningful in order to have that impact on improving the process. And things that seem to be best practices that would facilitate timeliness from the state's perspectives were looking at the process as a whole and tracking each step, ensuring integrated processes with smart data systems, and of course hospital education as well, interacting with their their stakeholders from whom they're receiving the specimens, the hospitals. We also then on that note thought, well, we should really know what's going on in the hospitals. And our grand plan had been, let's do a national survey of hospitals across the United States and get a sense of what of their processes are and how they differ, and do they differ by things like volume, geography, location, et cetera. Well, it turns out I could get the actual hospitals and I could pull the sample, but the challenge, which has been a continued challenge, I would say, of my career in this area, is who holds the knowledge and where does one find it? You know, when you have projects where it's, I want to know, I'll make this up, how program directors of pediatric residency programs view X or their experience with Y, I can say, oh, I know who the program director is. I know who it is. There's one person identified, and I'm going to find who they are, can locate them, and they're the ones that hold the information because I want their opinion. When you're asking about a newborn screening process, a few things happen, and this was illuminating for me as well as helpful as I sit on federal and state committees, is that this is a process that in a given hospital involves multiple people, so the knowledge is shared. In addition, who it's shared amongst varies widely depending on the hospital. So the hunt, if you will, for the information and who knows who holds that information is very labor intensive and often can be wrong. There are people that will tell you they know what happens in the process, but they speak from ignorance. And that threatens the validity of the data greatly. So we decided rather than rather than create a wide net of data that was potentially invalid, but not even representative, but from a broad sample, we would focus on a narrow sample first to see, basically test that we could get this information from hospitals in which we had good relationships because they had been in contact and worked with the Michigan Department of Health. So we surveyed several hospitals about their activities related to newborn screening. And these were semi-structured interviews as well that occurred over a longer period of time because there were issues actually identifying and getting the recruitment, because these are busy people. These are people on the wards of the hospital doing jobs and not always there and able to sort of contact us. And we, again, queried the following domains of activities and related policies, the time to complete these activities, the process constraints, and what aspects they felt were most important in improving the timeliness. So we got 7 sites to consent to an interview of varying sizes and they did varying locations, urban and rural. And the interviewees, as I mentioned, varied from nurse managers to hospital quality assurance coordinators to lab staff, phlebotomists, and then the individual interviews included anywhere from 1 to 7 stakeholders. So that's what I mean by sort of a group home of the information, if you will. And what we're working on now is the final parts of the analysis to go through the results that I've mentioned before and get a sense of what are the processes and procedures that are differ, similar, as well as gaps and potential best practices. And hope that this is at least a start to a more systematic look at what goes on at the hospital level for newborn screening. And so the potential, and I'll end here, the potential opportunities for future funding is that I think the best next life for a project is to not go on the shelf or go in a journal, or even to be disseminated is one thing, but if we can take it and build off of it, that's, to me, a win. And so what has come up is, for Dr. Cochran actually gets credit for this, devising an idea of having basically a web-based tool that will allow each state program to enter in data that are most critical to the newborn screening process, and then let them essentially identify the leverage points in their program and see, well, if I changed the lab hours, what would I do to my specimens? If I changed the courier times, what would happen? If pickup times, if I changed, if I doubled the courier a day, if I changed this or that. And so we are working with HRSA and have promising conversations about the ability to fund this tool, which basically would convert our model from a static assessment of process links to something that's much more interactive and useful on a day-to-day basis on the ground. So I want to acknowledge my team, who again who we couldn't have done it without. But this was a true multidisciplinary effort of all sorts. I have had healthcare engineers, health services researchers, health economists, epidemiologists, quality improvement experts, as well as a cadre of experienced, dedicated, and talented project managers at both the University of Michigan and the University of Iowa, without whom this project could not have been completed. And as well, my advisory committee, which we sought to include a number of stakeholders at all levels of a newborn screening program, as well as the newborn screening community, both nationally and all the other stakeholders nationally as well. And of course, this could not be done without the PHSSR support that we received, which I think has been money well spent to start to make incremental headway in improving a very important system that touches the lives of 4 million newborns in this country every year. And with that, I'll end and open it up to the commentary and questions.
Thank you, Beth. And our commentator for today is Dr. Julia Costich, who is a professor in the Department of Health Services Management, and she also serves as Associate Director of the Kentucky Injury Prevention and Research Center. Julia's current research focuses on legal and policy issues in public health and healthcare, health reform, and electronic health information exchange. She previously served as department chair and also director of the Master of Health Administration program, and also director of the Kentucky Injury Prevention and Research Center. Before joining the UK Public Health faculty in 1998, Julia administered academic medical programs, practiced healthcare law, and served as a policy specialist and administrator for state healthcare programs. So with that, I'd like to turn it over to you, Julia, for your commentary.
Thank you, CB. This is a subject that I have tracked informally for a long time, but more recently had the opportunity to study in depth when I was doing some work for the Office of the Assistant Secretary for Planning and Evaluation a couple of years ago, and the results of that work appeared in Public Health Reports this past January. So, since I have taken a deep dive into this subject matter, I fully appreciate just how difficult the work is and how complicated and variable these processes can be. So having this tool, the web-based tool, which I hope becomes accessible, is going to make a huge difference, not just in newborn screening, but I can certainly see implications in other areas of public health management at the state and local level. The successful execution of newborn screening requires interaction among agents that at the systems level are not optimally organized for seamless transitions and handoffs. This problem is certainly not unique to newborn screening, but because so much goes on in newborn screening, as Dr. Tarini noted, 4 million births a year generates a lot of test cards. We can perhaps study these transitions across types of systems and agents more effectively in newborn screening than in a lot of other areas. But it's money, isn't it? We can't just open the lab when we want the lab to be open. That can be quite an expensive proposition. So demonstrating the effectiveness of specific expensive changes in system operations is very important, and I applaud Dr. Tarini and her team in their plans to collect information in this area. It's hard. The project I was doing had a financial aspect to it, and it really becomes quite baffling. And there are two main reasons I'd like to point to, two main obstacles to getting a real grip on cost information. The first is that labs do a lot of work other than processing newborn screening cards. And it can be very difficult, if not impossible, to disentangle the specific costs attributable to newborn screening. The other is that states actually, some states do a better job of this than others, but states do capture some of the revenue stream associated with newborn testing. So it's not all just on the expenditure side of the ledger, as it were. This is particularly true with births covered by Medicaid. So attaching a dollar figure to strategies may involve just the same kind of dynamic modeling that's being used with the time parameters in the current model. But at the end of the day, we have to remember why this kind of testing takes place and why timeliness is important. There is credible evidence that lack of timely processing has led to a handful, but even so, a tragic instance of avoidable infant deaths. So there is public support for process improvement in this area, or at least if the public is made aware of the issue, there's the possibility of public support. And I really do feel that this kind of modeling tool has a lot of promise for broader dissemination of these important findings. Thank you.
Thank you, Dr. Costich. And I'd just like to remind everyone that if you have questions for our speakers, whether the presenter or our commentator, please do type them in the question in the chat box. And before we get to your questions, we'd like to give Dr. Tarini a chance to respond to the comments. Dr. Tarini?
Well, sure. Thank you. Dr. Costich, you have said it more eloquently than I can, so thank you for that excellent summary. You clearly get it, the complexity and then the issues at hand and the challenges. And also thank you for pointing out that, that at the end of the day, this is really about not time that translates into lives, and lives that could be lost, that could have been saved, or are impaired irreversibly in some ways because we couldn't get things done in as timely a manner as possible. So I thank you for that. And then I echo your points about the challenges with the costs. We originally thought, okay, we're going to collect the costs. We know they're not going to be, people have had trouble in the past of getting them, but there's a cost committee that is part of the Secretary's Advisory Committee, and we're going to go and work with them. And they basically said what you've just said to us. They said, we don't have good costs for a number of reasons. Exactly as you said, the states don't collect them. It's hard the revenue streams are different. And some of these things are not yet quantified. So we faced at one point, and I think this is still important, the potential of doing a time study. Dr. Prosser said what you would do is basically go around the hospital and just do a time study and then estimate the costs based on every individual who touched that specimen and what they were doing. And at that point, while we wanted to do it, was outside the scope of this project. But I think it's an important piece of the puzzle that needs eventually to be addressed. So I think that we have to do a better job of costs, not because we're pricing lives, but because we are using public health dollars and resources, and they are limited. And so we have to understand where our resources are best, where we get the best return essentially on our resources. So thank you. I just want to thank you. That was a great commentary. And I hope in the future we can find ways to collaborate.
Oh, that would be terrific. Let me give an example of the cost variation that is quantifiable. This is for the hearing screening component, which is one of the 2 point of service kind of tests that are done, point of care tests. Some hospitals use volunteers, highly trained volunteers, but volunteers all the same, to do the hearing test. So there is essentially just the minimal cost of training the volunteers, while other hospitals outsource hearing testing to a third-party commercial, for-profit, publicly traded corporate vendor who charges $300 or more per test.
Wow. Wow.
So
and that's just one disorder. And that's just one disorder.
Yeah, that's just one piece of this, yes.
Excellent discussion. And so we're now going to open it up to questions from our audience. We hope to get to your question. We have a few minutes for that. And we have one question from Aaron, who asked, Dr. Tarini, I'd like to hear from states that have surveyed their hospitals. Dr. Tarini, are you able to share the questions you used in your interviews with them? I'm working to improve the system in D.C. where we only have 7 birthing hospitals, and your comment about who holds the knowledge really resonates with me. So, Dr. Tarini, are you able to share your questionnaire, your search instrument?
Certainly, I don't have it in front of me now. I can tell you the general architecture of it, and I'm happy to share the questionnaire with Eric. If he wants to send me an email, we're happy to return it. It was a very simple questionnaire, and what we found is that there was no assumption that should be made. Like, we literally could not ask questions with an a priori assumption of what processes were going on. So this is where we got to this semi-structured, very open-ended. We had hoped to sort of say, tell us, X, Y, Z, and do a more, confined response survey. So what we basically did is, I'd done this for other newborn screening projects. We asked them to take us through the entire process. And so we literally walked them through phase, essentially by phase. Like, tell us what happens when the specimens arrive. And then they'd walk us through the processes, and then we'd use probes to make sure that they got us, we got most of what we were looking for. And then, of course, if something interesting happened, we would go off with them. And then we'd say, okay, walk us through the processing of the testing. How do you do that? And so then they walk us through, and then we'd probe on the different pieces of that. And then we'd say, okay, walk us through the results piece, and then walk us through finally the notification piece, with some guess and some anticipation of where we wanted to probe of, do you prioritize, for instance, because we had known just from being in the community that these were areas where the sort of key stakeholders had said they could have leverage points of improving the efficiency of the process. So that's basically how we did it. And then at the end, we asked them to reflect and then tell us, where do you think there are areas of improvement, what do you think that there are gaps, things like that, to sort of give us their reflection on what both in their eyes, what they felt at their lab, as well as sort of sometimes more writ large across the nation. Because these individuals, when you speak with the directors of the laboratory, this happened as through my interactions with many of on the advisory committee. They've been doing this for long enough that they have seen where they think that there are areas for improvement. They may not have been able to affect them, but they've thought about it certainly, and they are the content experts in this area at the ground level. And so it was very helpful in that way to have them both take us through, so we actually knew what was happening from the horse's mouth, if you will, rather than from like someone else who swears that that's actually the truth. And that's what I found to be like the most challenging part of newborn screening is you can have information, but the question is the information you have valid. And just because someone told you they know it doesn't mean it's valid. It's trying to understand that what you have actually got the person who is the expert on that process that you're asking about at that state program in that particular piece. So again, I see Aaron has sent the email, and we'll pull that off and send you the interview guide. Pulling it off right now.
All right. Well, Beth, I think that will definitely be a useful, toolkit and product out of your research too as well, to assist other states who want to carry out this type
Certainly.
of research. Yeah.
And improve on it. I'm sure there's ways in which the toolkit, the survey, could be improved.
Yeah.
So I'm happy if others think there's ways to iteratively change it. That'd be great.
Excellent. I think we have time for another question from Evelyn, who asks, with UN hearing screening, loss to follow-up for 50% for critical intervention still is a challenge. So are you evaluating linkages for follow-up? Early intervention has to be, I think she wasn't able to finish the sentence, but if you have an idea what she was trying to ask, Dr. Tarini?
I think that I do. That we focused on this project on, the lab. As I mentioned, we only focused up to the lab arrival, and then the processes came out in the surveys, interviews. But this has been a struggle in the area, and Dr. Costich mentioned it in terms of cost. Hearing screening has been a struggle for newborn screening, and in the most widely acknowledged way is the follow-up. And I have been interested in the challenges of the hearing screening follow-up just from being a systems researcher and a process enthusiast, because we seem unable to crack them, so to speak. And I do wonder, what is it about the inability to get these children to follow up? And I have a sense it's a multifactorial issue of both psychology as well as communication. I don't think that it's all that we just can't find them. For some reason, they're not coming back as well. And what is it about? For instance, one theory I had was that this is one where something about the parents say, "Yeah, the kid hears fine, it's fine," and then they just don't come back. And is there some sort of education / psychology element to this as well as a process issue as well? So I have not. Hearing tends to be its own group often in newborn screening, and the metabolic and other disorders tend to happen in another group. So I've not yet, at least in the state of Iowa, sort of crossed over, but certainly when I was sitting as the chair of the Michigan Newborn Screening Quality Committee, I would listen to these issues while we were doing this grant and wonder how could we sort of crack that nut and help solve this problem. So it is an area of interest, and anyone out there interested in looking at this or has ideas, please feel free to contact me.
Excellent. So if the audience has any more questions they'd like to add, they were not able to type it in, please feel free to either directly forward it to Dr. Tarini's research team or her contact address, or we'd be happy here at S4A to also forward that to as well. And so I guess final question, Dr. Tarini, just going back again to your simulation model, which was really provided some interesting results. The first part is the sample that you had. You said there was 83 birthing hospitals. Yes. Would you have information on how many of the NBS labs were part of that sample?
It all went to one lab.
Oh, okay. So just
it all went to one lab in Lansing. Yes. In some state, sometimes one state does multiple. One lab in a state does multiple states. In this case, there was one lab, and it just did Michigan. Largely.
Okay. Thank you for clarifying that. And also, I guess the template for that simulation model, you said that at the end, there's the recommendation of switching the sort of the pickup schedules and the consideration of cost of changing career lab schedules. I guess, was your model able to do some preliminary, just playing around probably with possible cost values or cost changes?
Well, actually, I'm pleased to say that as a result of doing this simulation with the Department of Health in Michigan, they actually reassessed. I wasn't part of the analysis. I had left and transitioned to the University of Iowa, but I still keep in contact with them and collaborate with them. They had, it happened that the contract with the courier, I believe, about a year ago now, came up for renewal. And given that we had this project and then had this thought-provoking conversations about how do we think about what do we want out of the courier and what services and how do we structure it, they said to me that this simulation played a very important role in how they approached it. And they may not have used the model directly, but they certainly used the principles and the elements of what we were trying to do in critically assessing the renewal and what the contract, I should say, of the courier and what they needed and how they should approach it. So I was very satisfied that we had made that step with them to sort of say, it's not about the cheapest, it's not about the most expensive, it's about what do we need, and then what is the cost and what are the trade-offs. So I don't know to answer your question about cost, but they were certainly looking at the different features of the courier and how that would impact things at the state level.
That's still an excellent example of an evidence being used as an actionable result.
Yes.
I think that's why I found it fascinating.
I have to thank I have to thank the RWJ not only for the Robert Johnson Foundation trained me in my fellowship as a clinical scholars program, but I have to thank the RWJ, especially the PHSR, because this type of research and work is very difficult to get funded, yet it can have such impact on processes and therefore public health and health outcomes for the population. And so I really am grateful that this is the type of investment that they think is important to make. So thank you.
Well, we thank you also, Dr. Tarini, for that wonderful and excellent presentation. And we'd also like to thank our commentator, Dr. Costich. We'd also like to thank everyone who joined us today for today's webinar. We'd like to let you know and remind you that today's webinar, along with past webinars, are available for download on the Systems for Action website in our webinar archive series. So we'd also like to invite you to our upcoming webinars too as well. We hope to see you there. So again, thank you, Dr. Tarini, Dr. Costich, and thank you to our audience. And we wish you all have a great day, and hope to see you guys again soon. Thank you, and goodbye. You too. Bye-bye.